Hello everyone, so now we continue with our discussion of infectious diseases. So when you see vomiting, predominant food poisoning after eating food, someone came in from the nursing home, this is either Staph aureus or norovirus, okay? This is what they tell you. Alright, now there is the other case, the case after that. You see somebody who's 55, came in with cough, weakness, and then sputum culture shows Mycobacterium avium complex. They tell you, okay? And then they tell you the CT shows like nodular opacities with some cavities, and some bronchiectatic changes, and these are the features for Mycobacterium avium complex. So how do you confirm? They tell you, okay, what's the best next step? And the trick part that they want you to know is that you're gonna repeat sputum culture, and I'll tell you why. The reason is, to diagnose Mycobacterium avium complex, you need either 2 positive sputum culture results or 1 bronchoalveolar lavage or wash with positive culture, or transbronchial or lung biopsy with histopathological confirmed diagnosis of non-tuberculous mycobacteria. Okay, you need that because you're going to commend them to a long treatment, right? So you want to confirm the diagnosis, at least repeat sputum culture. Okay, and the symptoms, like in this case, cough, fever, weight loss, been going on for several months, and you see multifocal bronchiectasis and multiple small nodules and cavitary opacities on the CT. Okay, so that's kind of Mycobacterium avium complex. This is how you deal with it. Okay, now there is, when they say, okay, now you have a patient, this 52-year-old man came in with left mandible swelling. The only bacteria that causes mandibular swelling, okay, and inflammation, there's only one thing. Which one is that? And sometimes can cause, they can say there is a mass extending from the mandible raised, and there's sinus tract, sinus tract extend to the skin, causes blood drainage, There's only one bacteria that you'll be tested on for. What is that, and how do you treat it? They didn't ask you about the diagnosis. You know the treatment. If you don't know the diagnosis, you need to know the treatment. So this is actinomyces, and then you treat it with penicillin, okay? Just like syphilis, okay? This is what you want to do. Other features for actinomyces, you can cause dental caries, extraction, infected tooth, gingivitis, gingival trauma. So this is the risk factors for actinomyces, like dental caries, gingivitis, malnutrition, diabetic, malignancy or radiation. And then usually causes a chronic, slowly progressive, non-tender indurated mass in the mandible, extend through the tissue planes to form an abscess, fistula, and a draining sinus tract. And mandible is the most common site, so they're always going to bring you to tell you it's in the mandible. Okay. So now you have another patient who's 63, came in with fever, cough, hemoptysis, fatigue, night sweat. So everything, a lot of things can cause that, right? So you go immediately to the imaging. CT shows nodular lesions surrounded by ground glass attenuation. Okay. And then they tell you, okay, what's the best next step? What is the treatment? They ask you immediately directly to this treatment. So you want to know what's the diagnosis before you treat, right? So this nodular region surrounded by ground glass opacities, fever, hemoptysis. When you see that, this most likely aspergillus. Okay, so the treatment should be what? Varicocazole. Okay. And there are different types of aspergillus that you need to be aware of. Okay. There's one that associated with asthmatic, causes fever, wheezing, bronchial hyperreactivity, hemoptysis, treat with steroid and traconazole. This is called allergic bronchopulmonary aspergillosis. That's one thing. Sometimes it's just like fungal ball, cavity, sometimes asymptomatic. You just need surgical resection or embolization, or sometimes no treatment. Okay. This is simple aspergilloma, we know that. The third thing is chronic cavitary pulmonary aspergillosis. When you see more than one cavity, it's kind of the name tells you. More than one cavities, symptoms are more than 3 months. You can see IgG aspergillus antibodies positive, and there's lung fibrosis as well. This we treat with itraconazole or voriconazole. There are other two forms of aspergillus that's dangerous. There's one chronic necrotizing pulmonary aspergillosis, similar to the chronic cavitary pulmonary aspergillosis, but if it's an immunocompromised, it manifests in a more destructive disease. So you give voriconazole again. And there is invasive aspergillosis. You see something is called the halo sign. That's what we call it. Single or multiple nodules, with or without cavitation, surrounded by ground glass opacities. Okay, so this is what we call the halo sign. Okay, this is called pulmonary aspergillosis, and then you treat it with voriconazole again. All right, now we have this patient. Now we got a very important question. Okay, so somebody like 62-year-old man, he's on a ventilator for whatever reason, and then developed fever, cough, okay, like some worsening respiratory dyspnea, like lung symptoms, hypoxia, you know. You do chest x-ray, you see right lower lobe infiltrate, and then the patient is already on Zosyn, okay? And they tell you, okay, what do you do next? What do you add to that? Okay? So now they want you to know which one causes ventilator-associated pneumonia. Common organisms are MRSA, MSSA, and gram-negative organisms like Pseudomonas. So Zosyn can cover Pseudomonas, right? But you're missing the MRSA coverage. So you add either the vancomycin or the linezolid. Okay, and that's what they added in this. The answer was linezolid, and that's the answer. Okay, for MRSA pneumonia. Okay, now we got another case. Someone who's 42 came in with cough, fatigue, dyspnea on exertion. There is faint systolic murmur, hyperresonance to percussion on the right side of the chest. Okay, and then so you do chest x-ray, you see pneumothorax, right-sided pneumothorax, and bibasilar, reticular opacities, and thin walled cavitary lesion. And they ask you about what is the diagnosis. So what, and then this patient has HIV. So basically they're asking you what lung infection that causes pneumothorax, pneumonia, and cavitary lesion in an HIV patient most commonly. So which one? Anyone comes in mind? There's one very specific for HIV. Yes, it is PCP. Okay, pneumocystis jirovecii pneumonia. Okay, PCP pneumonia. Pneumocystis jirovecii pneumonia. Okay, because it can cause spontaneous pneumothorax. It happened in 50% of the cases, and usually the other clue they give you, lactate dehydrogenase level will be high. LDH lactate dehydrogenase will be above 450. This is a big clue. So if you have pneumonia with lactate dehydrogenase, it's PCP pneumonia. Pneumonia with relative bradycardia, that's Legionella. Okay. Pneumonia with nodules surrounded by ground glass, this is Aspergillus, you know. Pneumonia hemoptysis in alcoholic, that's Klebsiella. Okay. So this is multiple forms of pneumonia. Okay. Now this is the patient that they were asking you. How do you decrease catheter-related infection? This is basically how to decrease catheter-related infections, and the answer is chlorhexidine bath. Okay. because they want you to know how to prevent this, something preventable. It's usually, and they want you to know, like, now they, because we want to discuss that usually catheter related infection is more common in lower extremities, femoral more than internal jugular, more than subclavian, and you want to replace the catheter after 72 hours or 96 hours, so you don't want to keep it for a long time. Okay, and you want to do routine replacement is not indicated for central venous catheter. PICC line can be used for months. Okay, unlike the central line, you can keep it for very long. And the material, you want to do antimicrobial impregnated catheters. This is helpful. And then to prevent, you do chlorhexidine bathing in ICU patients, decrease risk of infections. Hand washing, we know that. Sterile technique before catheter insertion, and replace the catheter if there is suspected infection, if there is like fever, hemodynamic instability, if you do not, and then don't use the guide wire to replace it, just take it out, put a new one. Okay, this is very important to know. Now you see 26-year-old woman came in with left facial weakness from Connecticut. Okay, she's from Connecticut, came in with left facial weakness. What does that tell you? This may be Lyme disease. Okay, and then they will tell you that corneal reflex decreased as well, and then they tell you what is the complications of Lyme disease. That's basically, so Lyme disease, it's easy to spot on, but they tell you, like, they don't ask you about what's the diagnosis, they ask you what's complications of that. So this is, you need like 3-4 step level thinking. Okay, so they can give you a bunch of other features, decreased corneal reflex, you know, and then they tell you what complications if left untreated. Okay, what is the most common? They bring you, is it heart death, cardiomyopathy, or arthritis? Arthritis is usually the common complications after Lyme disease. Okay, so Lyme disease, it has 3 stages. Okay, just like typhoid, we talked about it, it has 3 stages. Lyme has 3 stages. Stage 1 is called erythema migrans. Like, there's fatigue, malaise, with like headache, neck stiffness, myalgia, arthralgia, just like diffuse symptoms. The most specific erythema migrans, that's what give it away. This is from days to 1 month after the tick bite. The early disseminated can cause like carditis, like AV block, cardiomyopathy, neurologic, like unilateral or bilateral, cranial nerve palsy, like this patient had facial nerve palsy, meningitis, encephalitis as well. Can cause migratory arthralgia as well, just like gonococcal arthritis cause that. Can cause conjunctivitis if you leave it untreated. Multiple erythema migrans or regional or generalized lymphadenopathy can happen. This happened weeks to months after the tick bite. And there are the late or chronic, which happen months to years after the tick bite. And 60% of untreated patients can develop arthritis. These are the muscular complications. Other complications like encephalomyelitis or peripheral neuropathy. Okay. And don't forget the erythema migrans. It's very typical for that. Alright, now we have 37-year-old man came in with tonic clonic seizure. Okay, and then CT shows several small cystic lesions in the cortex bilaterally with focal areas of calcifications. What infection touches the brain and causes several cystic lesions in the cortex and calcification? There is only one single, just like in the mandible, there's only actinomyces there. This one, there's only one thing, and the diagnosis is called cysticercosis. Okay, this is cysticercosis, neurocysticercosis, common in Central and South America and Sub-Saharan Africa and Asia. Okay, it causes headache, fever, obstructive hydrocephalus, confusion, radiculopathy, myelopathy of the spine, causes visual loss, eye pain, diplopia, and ocular. And then to diagnose it, you can do CT or MRI showing a viable cyst, like 5 to 20 millimeter round, hypodense lesion without enhancement. You can have edema as cyst that degenerate and causes calcified granuloma. And you can do ELISA for equivocal cases if you don't know, not sure. But sometimes CT is diagnostic, so that's why they give you CT and you shouldn't be able to know it. And the treatment for that, albendazole and or steroid to decrease the inflammation and swelling, okay? That's one thing. Now, another case they give you, someone came in, 33 man, came in with weakness, palpitations, dizziness, lightheadedness, live in Long Island. And they tell you what cardiac finding here. So they're testing clearly about Lyme disease, okay? Okay. And then they tell you they can tell you annular rash on the right thigh. Okay. So now sometimes they lead you with the questions, sometimes they lead you with the answers, okay? So this one, you can develop complete AV block, which is one of the complications of Lyme disease. We talked about it just a minute ago. Alright. Now this case is interesting. So if you see 37-year-old woman, okay, comes in with joint pain for 3 weeks, okay, and then she has mitral valve prolapse history and she has fever, okay, you see hollow systolic murmur on the exam, okay, C3 level low, there is fever, hollow systolic murmur, joint pain, fatigue, weakness, you know, it's been going on for 3 weeks. What does that tell you? She has a cardiac issue and then she has these symptoms, leukocytosis as well. So when you see this picture on the question, this should raise the alarm for endocarditis. So they say how to diagnose this condition, okay? You need a blood culture. Okay, you ask me why. That's a very good question. And the reason is, for endocarditis, there are two types. There are major criteria, there's minor criteria. Major criteria, either positive blood culture with Staph aureus, Enterococcus strep viridans, or echo showing valvular vegetations. Minor criteria could be predisposing cardiac lesion, which is, in this case, there is mitral valve prolapse. IV drug abuse, we didn't find it. Fever, okay, which is there. Embolic phenomena or immunologic phenomena, okay, and positive blood culture as well, okay. So there is like some joint, but there is immunologic phenomena that we have, or embolic phenomena. So to have a definite endocarditis, you need 2 major or 1 major plus 3 minors. So this patient, let's say you have 3 minors, around 3 minors, like predisposing cardiac conditions, fever, and immunologic phenomena. There's like, they can give you RBC cast or so, like glomerulonephritis. And then if you just have 3 minors, then you need 1 major to diagnose it, okay? If there is possible, you can have 1 major or 1 minor or 3 minors, especially 3 minors. So it is possible, okay? So to make it definite, you need blood culture. That's in this case, okay? What the other things that could present with fever, murmur, like we see in this patient, petechiae, Subangular splinter hemorrhage, ocular node, Janeway lesion, and you can have a neurologic phenomena like embolic, splenomegaly, Roth spot, retinal hemorrhage. You know, it's pretty important and life-threatening situation. So you need to know how to deal with that. All right, now we have another case, that interesting one as well. So you have a 50-year-old man comes in with fever and confusion. So fever, confusion, right? So what do? You do CSF lumbar puncture. Lumbar puncture showed encapsulated yeast. So they can give you, that's why I always go to the end of the question. Read the chief complaint and always go to the end of the question, so that this will, you will get your most questions right. So this patient already know that this is what diagnosis. So he started amphotericin B. And so the question is, what's the next step? What do you do after that? Okay. This is cryptococcal meningoencephalitis. So you want to do serial lumbar puncture. Why? Because there is very high intracranial pressure. And the treatment phases, it has 3 phases to treat it. There's induction phase, consolidation, and maintenance. The induction phase, usually amphotericin plus flucytosine, that's recommended, and then for 2 weeks. And then consolidation phase, you can do fluconazole 800 milligram daily for up to 8 weeks. And then maintenance is fluconazole 200 milligram daily for a year. So it's pretty very long treatment protocol for cryptococcal meningoencephalitis, common HIV patient. So it's pretty serious, right? Okay. Alright, the next question, they're telling you how to decrease risk of UTI, recurrent UTI, and the answer is remove the catheter. Okay, which kind of makes sense, you know. Then they want you to know like how to avoid the complications of UTI. Remove catheter, only use when indicated. Prompt removal of the catheter if not needed. Use alternative to the catheter like condom catheter for male patients, or diapers, you know. Okay, and then you don't need not routinely you need to replace or irrigate the catheters as well. Okay, alright, now this patient have vomiting 4 hours after food. And they ask what was the reason. This 50-year-old man, this is staph. Oh yes, can cause that. Okay, other reasons for this vomiting could cause Bacillus cereus, can cause that. It can cause also diarrhea, abdominal cramping, ingestion of preformed toxin from rice as well. Staph aureus can cause vomiting, abdominal pain, but it doesn't cause diarrhea. It's not typical, usually quick, rapid. We have Clostridium difficile, causes watery diarrhea, possible fever, cause abdominal pain as well, and doesn't cause bloody stool usually. Usually it's somebody who took antibiotics recently. Clostridium perfringens, usually brief illness, causes watery diarrhea, cramps, fever, and undercooked or unrefrigerated food. Perfringen and refrigerated food. Kind of, there are some words similar here. And we have 5 more. Salmonella, it causes watery diarrhea, abdominal pain from poultry and eggs. Okay, you need antibiotic only in severe cases. We have Vibrio vulnificus, could cause vomiting, diarrhea from shellfish, undercooked shellfish. Okay, and can be invasive or life-threatening in somebody who has liver disease, Vibrio vulnificus. And we have E. coli, causes bloody diarrhea associated with Shiga toxin and from undercooked beef or food containing bovine feces. Shigella also causes bloody diarrhea from contaminated food or water, especially during travel outside the US. So E. coli inside the US, beef, Shigella outside the US, okay? Campylobacter causes bloody diarrhea as well, and high in children and young adults. and associated with undercooked meat as well. So you see a bunch of them associated with undercooked meat, like Campylobacter, E. coli, Salmonella, Salmonella from chicken and eggs, but the others from beef. Okay. So that's kind of summary of the food poisoning. Now this question they're asking, how do you treat ESBL? What's best next step? Patient had ESBL. You give meropenem. Okay. They want you to know how to manage. There are risk factors for ESBL. It's pretty common. Somebody who's in the ICU, there is urinary catheter, venous catheter, feeding tube, prior antibiotics. There is someone in nursing home, ventilator. A lot of things that this is increased risk for ESBL, and this is pretty serious. The resistant bacteria, so you gotta be careful about it. Okay. So now they're asking you about a patient that has HIV, okay, and you need sulfa diazine permethamine, okay, for toxoplasmosis, okay. And they're telling you what best next step. What else you need to add to this medication? So this one you want to add leucovorin. Why? Because this permethamine inhibit the folate, and you need some leucovorin to prevent folate deficiency. So this is something important, can be missed, so you need to test. Other things that causes folate, like other than the permethamine, is trimethoprim and methotrexate and phenytoin. It's called MPPT. M methotrexate, P phenytoin, P permethamine, T trimethoprim. MPPT. Okay. So now this is also another devastating disease as well. Like, so usually it happened in 23 diabetic, type 1 diabetic, someone type 1 diabetes, have SLE, came in blurry vision, headache, okay, periorbital swelling and tenderness, So this patient, what do you suspect? That one diabetic has periorbital swelling, tenderness, and then if you do CT, you will see sinusitis, could cause cavernous sinus disease. What could cause that? It's called rhinoorbital cerebral. This is what it infect most common. Usually target HIV patients and type 1 diabetic. This is mucormycosis. Okay, whenever type 1 diabetic have like some swelling in the face, just think of that. So treatment is surgical treatment. You need surgical treatment because this causes necrosis. Okay, acute sinusitis in all sinuses with rapid local extension, cause periorbital edema, proptosis, could cause blindness as well. That's why you need to intervene. It can also cause cavernous sinus disease with cranial nerve palsy, thrombosis of the sinus, carotid artery involvement, causes pneumonia, hemoptysis with necrosis, causes peritonitis, perforation in the GI tract. So whatever it goes, it perforates stuff. Skin, causes indurated cellulitis, okay? And not just in type 1 diabetic with ketoacidosis, it happened with somebody with hematologic malignancy, leukemia, lymphoma, if somebody organ transplant, on a steroid, like for whatever autoimmune disease, someone with HIV, AIDS, someone have iron overload, chelation therapy with deferoxamine. So these patients are common. These are can predispose to this nodule. Okay. Now another interesting case. You see, 27-year-old man. Okay. He went to hike, and then after hiking had migratory joint pain for 5 days, along with cough, fatigue, skin rash, erythematous nodule, 2 to 3 centimeter in both anterior legs. And they ask you what's the diagnosis. This one is obvious in the southwest US as well. Okay, this is obviously coccidia mycosis. Okay, so this looks like a coccidiomycosis. Okay, desert, it's called desert rheumatism. It's causes joint pain in the desert in the south. I like this name, desert rheumatism, you know. Okay, this is coccidiomycosis. Now there's another case, somebody in the ICU that needed depressors. So what bacteria, what microbe need immediate CVL removal? Okay, what microbe is that? If you see it, you have to remove the CVL. There are a few that are very dangerous. So the most important one, Pseudomonas. If you see that in the blood culture and the patient have a CVL, you really need to remove the CVL. Okay. That brings us to the discussion: indications for catheter removal and central venous catheter associated infection. If you see not just Pseudomonas, if you see Staph aureus, Candida, or Mycobacteria, all of these four, these are big guys. You need to remove the CVL. And clinical infections can cause severe sepsis, can cause suppurative thrombophlebitis, can cause endocarditis, can cause persistent bloodstream infection more than 72 hours even after appropriate antibiotic therapy. It causes unstable hemodynamics. So this is big stuff, you know. It's called CLABSI, and the hospital got penalized for that as well. So you gotta be careful. Okay, catheter related, CRBC or CLABSI, CRBC, catheter related bloodstream infection. So you gotta be careful and remove it as soon as possible. Okay, now another case is kind of interesting. So blood culture grew Staph aureus, and they ask you this next step. They can give you long ass question about fever, fatigue, all these kind of symptoms. But whenever you see blood culture Staph aureus, you have to do echo immediately, reflex echo, like right away. Should be a reflex, because you really need to make sure the heart is not infected, because Staph aureus love the heart, needs love, so it goes to the heart and melt your heart. Okay, so you need to get rid of it. Now another case, you will see somebody with fever and lethargy. So fever and a headache, headache and a fever, and somebody who's 68. So 68, fever and headache. Okay, there's neck stiffness. Okay, so how do you treat that patient who is above 65, above 50, and that is best next step? So treatment is vancomycin, Rocephin, ampicillin, and dexamethasone. You see, four drugs you have to start. Okay, why? Because this, so anyone above 50, you suspect strep pneumo, Neisseria meningitis, or listeria. Okay, so that's why you want to add ampicillin. And so the official is just Rocephin and vancomycin, but you add ampicillin here. Why? Because above 50. Okay, you can add dexamethasone as well. So if somebody less than 50, younger than 50, from 2 years to 50 years, just vancomycin and Rocephin. Okay. Now you ask me, what if immunocompromised? You can't be treating them the same way. For immunocompromised, you switch the Rocephin to cefepime, so that you cover Pseudomonas in case the gram-negative roads. You want to cover that, can cause meningitis there. So you do vancomycin, cefepime, and you add ampicillin as well. Okay. What if somebody have penetrating, like trauma or a neurosurgery patient? Also, there's suspicion of gram-negative rods, MRSA, and coagulase negative staph. So you want to do vancomycin and cefepime. Okay. Alternative to cefepime, you can do ceftazidime or meropenem as well. Alternative to ampicillin, you can do Bactrim. Okay, can be helpful. Alternative to cephalosporin, you can do cefotaxime. Okay, And that summarizes this meningitis management. Okay, so now let's review what we talked about. We talked about vancomycin management, vancomycin, ceftriaxone, ampicillin, dexamethasone. We talked about pseudomonas is dangerous, desert rheumatism, coccidioidomycosis, mucorrhizable pseudosurgical treatment, okay. Leucovorin for certain drug, permethamine, meropenem for ESBL, Staph aureus if you're vomiting after food. Remove the catheter in UTI patients. Serial lumbar puncture for coccidioidomycosis and capsular disease. You want to do a blood culture for patient with halosystolic murmur. Okay. Complications of Lyme is complete AV block, cysticercosis. When you see calcifications on the brain, CT. Arthritis complication of Lyme. Chlorhexidine bath to prevent infection. PCP pneumonia can cause cavitary lesion and pneumothorax. Lactic dehydrogenase elevated. Linozolid and ventilator associated pneumonia need to cover MRSA. Voriconazole when you see a ground glass halo sign on CT. A blood thin drainage on the mandible. This is actinomyces. You want to do penicillin. Repeat superior culture to confirm Mycobacterium avium. Norovirus for vomiting diarrhea as well in the nursing home patient. And that concludes our discussion for this session, and we'll continue with the next one. Thank you for listening.